Good afternoon. Welcome to today's presentation using maps to provide quality health services. This webinar is part of a series hosted by St. Clair County Community Mental Health during the month of September, which is National Recovery Month. Today's session is being recorded and will be uploaded to the CMH YouTube account for future reference. Please feel free to use the chat box to ask questions and add comments that you have during this webinar. If time allows, we will answer as many questions as we can at the conclusion of the presentation. Our presenters today are Amber Daniels and Haley Winans. Amber is a department analysis and Haley is a specialist with the Bureau of Professional Licensing at LARA, Michigan's Department of Licensing and Regulatory Affairs. With that, I'll turn it over to you, Amber and Haley.
Thank you. Well, as she said, my name is Amber Daniels, and I am with the Department of Licensing and Regulatory Affairs, joined by my colleague, Haley Winans. And we both sit specifically on the MAPS team, which is the Michigan Automated Prescription System team. And I'm going to talk a little bit about some background related to that. But essentially today, we're going to go over really what the system is and then a little bit more about what we do on our team. And then we're going to walk through who has access to the system and specifically kind of what they have access for, and because Michigan law really restricts who can have access to PDMP or prescription drug monitoring program data. So we're going to go over all of that information, and then we're also going to go over some Michigan controlled substance data because a lot of people are interested in that type of information. And then just some other things that we get a lot of questions about that are happening in our bureau, things related to complaints that come into the department against licensees. And then I've also posted some information about controlled substance related laws, but there'll definitely be time for questions. If there's anything, generally we like to stop after each section and ask if there are questions, but certainly feel free. We can have an interactive session here to some degree. So if there's something that you're confused about, you can, and like she said, you can type it in the chat and we can kind of go from there too. So for those of you who might not be familiar with MAPS, it is, like I said, what's called a prescription drug monitoring program. And essentially what that is it's the system where all information about any scheduled 2 through 5 controlled substances that are dispensed in the state is reported to. And most states have a PDMP, I think with the exception of one state that doesn't have a statewide PDMP, they have more localized. But again, for the most part, pretty much every state has a PDMP. In Michigan, it's been around since 2003, but for quite a while, we had a homegrown system. And then in 2017, we actually migrated over to a Bamboo Health platform. And Bamboo, they have a ton of experience in the health IT related field. Not only do they administrate Michigan's PDMP, but they also administrate, I want to say 43 other state PDMPs, and they administrate the military health system PDMP. So they bring a ton of experience to the table. And really, when we migrated over to Bamboo, we had a lot of system enhancements and the capabilities to do things that we weren't able to do with our old homegrown system. So we hold over 100 million records in the system. We do maintain the data for 5 years. And again, it's any information about all scheduled 2 through 5 controlled substances that are dispensed in the state, with the exception of a few things, and I'll talk about that here in a second. But who is reporting the data would be anybody who's dispensing it. For the most part, that's going to be pharmacies, veterinarians, because a lot of those do dispense right from their facilities, and then prescribers who have a license specifically, who are able to do that, dispensing physicians, we call them, they would be reporting to the information as well, or to the system as well. And so there are a couple of exemptions from who's reporting to the system, and probably some of you are familiar with this, but 42 CFR, the Code of Federal Regulations, For a long time, they prohibited anybody who essentially in receiving treatment in methadone clinics, any of that SUD treatment related information could not be reported to any PDMP. So not only was that in Michigan, but that would be federally or anywhere. But in 2020, some of that changed, and they now do allow for reporting of that information if patient consent is obtained. I believe that we do not have any of that reporting happening in Michigan yet, but again, with patient consent, that is allowed. And then also, I talked about those dispensing physicians. Essentially, they don't have to report any quantities that fall below a 48-hour threshold. If it's above that 48-hour threshold, they do need to report, but they're not mandated to report if, again, it falls under that 48-hour supply. We do still see some of them reporting that information, even if it is within that 48 hours. But again, by law, they're not required to report that information. Also, I do want to say that a copy of this presentation has been provided. And so I'm not sure if it's been distributed to you guys yet, but if not, it will be. So you guys will have a copy of all these slides. So a little bit more background about our section specifically within the department and some more things that we do. So in 2016, our department established what was called the drug monitoring section. And essentially the goal of that was to identify, investigate, and pursue administrative action or take action against professional health licenses if necessary, for individuals who were overprescribing, overdispensing, or involved in drug diversion of controlled substances. And so originally the MAPS team was housed specifically within the drug monitoring section, but there was a lot of progress made, a lot of success with that pilot program. So in August of 2019, MAPS broke off. It became its own section, and the pharmacy and drug monitoring section, what was previously known as that drug monitoring section, became established. And now the two sections kind of work in tandem. They're kind of like sister sections, and they're doing a lot of great work, again, to still investigate those health professionals that would be involved in that overprescribing and overdispensing. But both sections sit within the enforcement division within the Bureau of Professional Licensing at the department. So like I said, the enforcement division is within the Bureau of Professional Licensing. It is one of three divisions. There's licensing, investigations, and inspections, and then the enforcement division. But the Bureau was established in 2015, and within it, we hold 13 occupational licensing and regulation boards, 26 health professional licensing and regulation boards. And one thing that I want to say about the boards is that all of those are advisory and determine any sanctions that ever have to be imposed against somebody with a professional license. So I'll talk about this more toward the end of the presentation, but essentially anytime there's a complaint or something that happens against a licensee, there's a process that has to formally be gone through, and that would be put up in front of the authority board of whatever that professional license is. And they're ultimately the ones who would determine and impose the sanction against that individual. Overall, we license and regulate over 750,000 individuals. So who has access to MAPS data? And then I'll get a little bit more into specifics of that. So any type of prescribers, which in the state of Michigan would be MDs, DOs, physician's assistants, nurse practitioners, dentists, optometrists, podiatrists, veterinarians, midwives with prescriptive authority. And then one of the enhancements when we converted over to the Bamboo Health platform was the ability to have delegate access for those prescribers. And essentially, this would be anybody that a prescriber elects to access the information on their behalf. And so they could register to the system specifically as a delegate user and then kind of connect their accounts, if you will, with that prescriber or prescribers, dispensers or pharmacists. And then pharmacists also have the ability to have delegate users, and that would be either a pharmacist intern or a licensed pharmacy technician. Law enforcement agents can have access to the system, but it's definitely conditional upon meeting statutory limitations. And again, I'll talk about that very briefly in a few minutes. Representatives of state boards, and again, this would be for the purpose of imposing licensing sanctions if necessary. Again, that would be conditional upon meeting the statutory limitations. Benefit plan, what we call benefit plan managers, but essentially these are healthcare payers. And again, this would be conditional upon statutory limitations. And then system administrators. I always put this in here because this is one of the most important pieces of legislation related to the PDMP. And essentially that is that anytime somebody gains access to information in the system, they cannot share that information with anyone for any reason unless it's ordered by a court of law. So essentially subpoena. So whether that's a prescriber accessing information, whether that's one of our state administrators accessing information, we can't share that information with anybody for any reason. Again, unless we're court ordered to do so. So prescribers and pharmacists, and this of course would include their delegates that might be requesting information on their behalf. So essentially is what the law says is the reason that they can access information in the system is for the purposes of providing treatment to a bona fide current patient. So essentially this would be, if they want to see what's going on with that patient and their controlled substance history or their current use of controlled substances for the purposes of treating them. And so this doesn't necessarily mean that they have to be pulling it just because they want to treat them with controlled substances. Generally speaking, I would assume that that's one of the reasons that somebody would access the data, but it doesn't necessarily mean that that's what their intention is. They might just want to see what they have going on with controlled substance use to be able to appropriately treat them in another way, but they should only be doing it for the purposes of actively treating and engaging a patient in care. And so, as an example, Dr. Brown couldn't access my MAPS information, if he was somebody who knew me in his personal life, or if he was my neighbor and he just wanted to see if I was on any controlled substances or using any controlled substances. Again, unless I was a current patient and he or she wanted to treat me, there wouldn't be any lawful reason to pull information. And then also it does allow a prescriber to access system data for the purposes of seeing what prescriptions have been attributed to their DEA. And so a lot of the times we recommend to prescribers, hey, if you want to see what's going on with your prescribing history, if you want to make sure that everything seems accurate to what that you've prescribed, it would be a good idea to get in and look at your history, your prescription history within the system. So there are allowances for that as well. Law enforcement. It has to be a state, federal, or municipal employee, essentially whose duties it is to enforce the laws of the state or the federal government. And it has to be related to a bona fide drug investigation, essentially. And or it can be a state, federal, or municipal employee who's the holder of a search warrant or a subpoena properly issued for records. And so, and again, it has to be for a bona fide drug-related investigation. So a lot of the times, or I shouldn't say a lot of the times, we have certainly had times before when, I apologize, it keeps blurring me in and out here. I'm not really sure why. A lot of the times we have law enforcement who might just be trying to locate somebody or see where the last known place that they might be. And so they think, oh, well, we can run a MAPS report and we can see maybe where the most recent place they filled a prescription at. And unfortunately, we're not allowed to release information for that purposes, unless, again, it was related to a drug investigation, because again, there has to be that drug component or that drug investigation component involved. So law enforcement definitely can't be pulling the information just for any reason that they want. A representative of a state board, that would be somebody like myself or Haley. We do have 6 of us on our team, and so we would be, oh, I'm sorry, no, we're department administrators, the representatives of the state board. I apologize. This would be a representative of one of those licensing boards that I talked about. And these would be the individuals who would be responsible for the review of complaints that would be coming across the board. Essentially, again, those individual authority boards. So, the Board of Medicine, the Board of Nursing, the Board of Pharmacy. And again, this would be so that they could potentially regulate a license or impose sanctions or discipline if necessary. The healthcare payer, or those benefit providers, or what I earlier referred to as a benefit plan manager, they can review this information for the purposes of ensuring patient safety and investigating fraud and abuse. And then I just pulled kind of from the statute the definition of that benefit care or that benefit plan manager, just so people have a little bit better understanding of who that would fall under. But a lot of the times, for example, this would be somebody working for Medicaid or for Blue Cross Blue Shield. So they would, be again ensuring patient safety or investigating that fraud and abuse. And so they would be requesting information for those purposes. Now we're on to the system administrators. And this is where there's 6 of us on our team. So like Haley or myself, and that would be an employee or agent of the department. And essentially that's for upkeep of the system, for a lot of different things that we do that are related to the system, reviewing data, things like that. So again, there are 6 of us. And I will say, while we do have open access to all of the system information, we cannot just access records for any reason. It has to be in accordance with our job responsibilities. And so in the same way that, a doctor couldn't just go and pull their friend's report or pull their neighbor's report to see what's going on, I can't go in and pull my friend's information or whomever. I can't even go in and actually pull my own PDMP report because there's just not allowances for that in the law. And so it does have to be in accordance with our regular job responsibilities and duties to look at the information. And, just like most other jobs, we do have auditors and people who are making sure that we're doing what we're supposed to be doing. And then I just like to give a snapshot of some of our registered users. So you can see prescribers, we have just short of 60,000. These numbers I pulled last week. And pharmacists, we have about 10,500. Delegate users, just under 28,000. Law enforcement, we have about 3,000. And then benefit plan managers, we have about 150 registered users. NARCS care report. So these are going to be actual reports that are pulled from the system, and I am actually going to turn it over to Haley, and she's going to talk a little bit about these, and then we're going to get also into some more specific controlled substance data for the state.
Thanks, Amber. Thank you all for joining. It looks like we have a pretty good turnout today, just under 50 attendees. I do apologize if you have already seen these next few slides, or you're, day in and day out running patient MAPS reports. This is probably just going to be a refresher for you. Hopefully, it helps in some capacity if you've never seen a MAPS report, or if it is just a refresher. Next slide. So when you run a patient MAPS report, NARCS Care is an additional analytics tool that we've added on to MAPS reports. So you get these scores and these graphs. I'm just going to run through these and kind of explain a little bit of what they are. And then we'll get into some data slides after this. So the next few slides are actually a continuation of one MAPS report when you run on a patient. So anytime you run, at the top, you're going to get these 3 sections for different scores and red flag indicators. The NARC scores, for one, you get a narcotic, sedative, and stimulant risk score. So these scores are based on the 2 years of prescription data for this patient. A new calculation is generated each time you run a new patient MAPS report. And same with the overdose risk score. That score is there just to give a visual, not really a visual, it's a number, just to give you a little bit more information if the patient could potentially be at risk for abuse or misuse of controlled substances. Underneath each of these sections at the top, so the NARC scores, the overdose risk score, and those red flag indicators, there's where it says explain these scores, explain the overdose risk score, and explain these red flags. Those are actually links, and those give a little bit more information on how they're calculated. They're very specific algorithms that are proprietary for the full algorithm to Bamboo Health, but it does give a little bit of insight on the criteria used to calculate those scores. And then the red flags, currently there are 3 different red flags that you may see. There are the dispensing pharmacy. So if a patient has seen 4 or more pharmacies in any 90-day period of the 2-year report that you run, that alert or red flag would appear. Any equal to or greater than 5 providers in any year of the last 2 years, so the 2-year report. And then there is also an MME per day, which it must be 40 MMEs per day and 100 total MMEs for the prescription or active prescriptions. That's the threshold, the 40 MME per day average and 100 MME total for the entire prescription or prescriptions. And then if that threshold is met, an alert will appear for that as well. It does, so within the links for the explanations of each of these, it does give a little bit like resources that have been used to create these algorithms and the scoring. But if there's ever questions, feel free to contact us and we can help you out on those. We can't tell you. When we initially launched NARCS Care, we got the question quite a bit, if a patient's score is above X, say 500, can we still prescribe to them? And we're not here to tell anyone how to prescribe or practice or treat a patient. You're the provider, the user treating the patient. So they're just additional tools that we've added onto the MAPS reports to help guide and just have the best insight into the patient and their prescription information. So beneath those scores, there's a graph. It's color coded by narcotic, sedative, and stimulant. So there's the red, blue, and green. And then it lists all of the prescribers in the report that for the time period that you've run. So you can visually see if there's any overlap in the drug types between providers. This one is just a sample, so you only see the red here, but you can see that there is some overlap between providers and the patient receiving narcotics from different providers. Next slide. you can sort of see it at the top, the morphine milligram equivalent per day. You can kind of see how that's fluctuating amongst this patient based on the prescription data. And then beneath the graphs that appear on the report, you will see the line-by-line prescription data that you're likely used to seeing. Even in our old system, you only got that line-by-line prescription data. And before we implemented NERCS care, that's what you would have seen. So you're going to get the fill date. So that's, well, the day it was filled. You get the drug name, the strength, the quantity. So that's the number of dosage units that the patient received and that was dispensed by the pharmacy. The day supply. You get a shortened version of the provider or the prescriber's name, and then that's it coincides with the prescriber section at the bottom of the report. You get the pharmacy where it was filled, the refill number. Again, you get the morphine milligram equivalents per day, but also the total MMEs across the entire prescription. The payment type, so, was insurance billed? Was it Medicaid? Was it private pay, which would mean no insurance was billed? And then the PMP. So this is a sample report from Ohio, but we are connected. Michigan MAPS is connected to, I believe it's 37 other state PMPs. So if if you're a user role within MAPS that is allowed to search other states and you have a bordering patient state, you can select that state and receive the data. If the patient has gone to that state and filled prescriptions and it's been reported to their PMP, you would be able to receive that on a MAPS report. So that's going to tell you what PMP or what state that information is coming from, all included within the MAPS report. Next slide. Beneath the line-by-line prescription data, again, is the summary of the prescribers or the providers and where they're located. This is just, if you need to contact one, that information is available. It does not display, this is a slightly older sample report, but it doesn't display the DEA number any longer. But the other information should be available to you. Next slide. Beneath the provider information is the pharmacy summary information. And again, the DEA is also no longer available for the pharmacies. Next slide. So this is an additional resource tab, and I forgot to point it out at the top, at the very top of the report, which you can kind of see here. That resources button in the middle of the page, that appears at the top of a patient NARCS care or MAPS report. If you click that, that's going to bring you to this page. That you can search the 30 closest MAT providers for a patient if they need to be referred into care. And then there's also additional educational resources below that you can open, review, download, and those are all pulled from CDC. The MAT provider list is connected to SAMHSA, so whoever is enrolled or available for searching through SAMHSA, it's my understanding that's voluntary. So if a provider who provides MAT care is listed in there, then they would be listed here as well. Next slide. And again, these are just additional educational resources all pulled from CDC that are loaded right into that resources tab on a patient MAPS report. So you can open those, download them, save them, print them, whatever you choose to do, those are there for your use. Next slide. This is just to give a visual of how many requests for patient reports our system processes on a monthly basis. So far over to the left, that would have been about a year before we launched with APRIS. You can see we didn't even reach 400,000 a month. Mandatory use took effect there in June 2018. Haley, yes.
I just wanted to point out that Bamboo Health was formerly known as APRIS. So that's what she's referring to when she says when we launched with APRIS. Sorry.
Sorry about that. So in May of 2018, you can see it started to incline because that new legislation for mandatory use was taking effect June 1st of 2018. And since then we've, it's fluctuated a little bit, but for the past year or so, we've ranged between 1.5 and 1.7 million requests per month. So we've seen quite a bit of an increase in the use of the system. just once we migrated to the new system, but also because of that mandatory use component. Next slide. So with that, are there, it doesn't look like there's any questions in the chat. I guess, Amber, we'll just wait until the end to see if there are any, and we can go back to the slides if we need to. I have some data slides now, and again, these are just expanded on from previous years, you know, just to give a visual of where we're at in Michigan. So I apologize if this is repeat information for you. I do have preliminary 2021 data, and I will say normally the prior year's data would be finalized already. And I don't see that the numbers for 2021 changing too often or too much until, you know, before we can run the finalized report. It's still preliminary just because the reporting tools that we use to create that large annual drug utilization report is undergoing a data refresh. And they're adding some additional things in there. So we haven't been able to run it all quite yet. But you can see in 2021 from 2020, we only had a slight decline in the number of prescriptions dispensed in Michigan, controlled substance prescriptions, and that's same with the dosage units. So we have both here, the number of prescriptions, but also the dosage units that were dispensed. And I just want to point out, Amber had mentioned in 2016, we had the pilot program to reduce overprescribing, and that's actually the first year that we saw a decline in the number of controlled substance prescriptions in quite a while. You know, for the past 10 or so years, it was mostly inclining or increasing. So we, you know, like to think that our work is doing good, but just overall in the entire state, all of the initiatives taking place have likely played a role in the decrease in controlled substance prescriptions. And then pointing out 2019, you see that increase there. That is because gabapentin became a Schedule 5 controlled substance effective January 4th, 2019. So those prescriptions for gabapentin had to start getting reported to MAPS. So there are a lot of gabapentin prescriptions in Michigan, but we are collecting those now. Next slide.
And I just really quickly wanted to note that a large portion of the gabapentin that we see prescribed in Michigan come from the animal medicine community. So veterinarians, they prescribe a big portion of those. Haley, I don't know if you said that, maybe you did, but I
did
missed
not.
it if it did. Okay.
Thank you. Next slide. This is breaking out opioid prescriptions in Michigan, excluding those that would be for opioid use disorder. So your Suboxones, the Zubsols, you know, those formulations, those are excluded from these counts. Prior to probably a year or two ago, we just had it all included in one group for presentations, and it's not really giving a good visual. You know, it actually looked like we were increasing a number of opioid prescriptions. So what were we doing wrong? So we separated them out, and we're actually, so these would be what, for pain? Yes. We have seen that is actually decreasing over the years. And we're excited to see that. It looks like it went down in 2021, again, preliminary 150, well, actually slightly over 150,000 prescriptions from 2020 to 2021. And same goes for the dosage units, not as many as 150,000, but it was a decrease from the previous year. Next slide. And then on the flip side, this is specific to those opioid prescriptions specific for opioid use disorder. We are seeing those increasing. So the Suboxones, again, we are seeing an increase in those number of prescriptions and dosage units being dispensed to patients. So we do like to think that that is a good sign. We're getting patients into treatment for opioid use disorder, OUD, and hopefully getting the help that they need. Next slide. The next few slides, I've just expanded on, you know, the data within Michigan to look at it by drug schedule, and then we'll also have the number of patients receiving opioid use disorder or MAT medications in Michigan. So this you can see over the years, Schedule 2, Schedule 3, Schedule 4, all decreasing. And then Schedule 5, you see increasing. Again, that's because of the gabapentin scheduling, we saw quite a big increase in the Schedule 5, and that's staying fairly consistent now once that was scheduled. Next slide. This is, well, numbers, but also to show visually the decline and, well, the increase. So the opioids not for MAT or OUD, so that blue line at the top, we are seeing decrease. The number, and this is specific to dosage units, so not number of prescriptions. We like to look at it by dosage units. You can have a prescription written for 300 tablets, but just the one prescription. So we like to look at it at the dosage unit level. The benzos are also going down. That's that gray line there. The yellow, this are stimulants, and we're actually seeing an increase in those. We saw a slight dip in 2020, but it's actually gone up again for 2021. So we are seeing an increase in that. And in just various conferences and presentations that we've listened in on, it sounds like stimulants are the next problem or are already a problem. So that would make sense why we're seeing it increase. And then at the bottom, as I've mentioned, the OUD opioid dosage units, those are increasing. And that's all for patient OUD or MAT care. Next slide. Here visually you can see, so over the years, how many patients, so this is specific to Michigan as a whole, how many patients are receiving opioid use disorder, opioid medications. You know, over the past 5 years, we've seen an increase in over 10,000 patients getting care. So, I mean, that's good. I'm sure there are more out there that need care, but we're doing good work here. Next slide. This, as Amber mentioned, gabapentin, once it became scheduled, it had to start being reported, but a lot of that is from the veterinarian world for animal care. However, it is a top drug that we see dispensed, and it has been since 2019. Then next to that is you're going to see the Norco, the 10 milligram strength, the 10 milligram 325. That's stayed. Tramadol 50 milligram is very common and has been a top 5 drug dispensed over the past few years. And then you have the Norco or the hydrocodone acetaminophen 7.5 milligram and the gabapentin 100 milligrams. So the gabapentin 300 and 100 are our common dosages that are being dispensed. And these top 5 drugs have remained pretty much the same over the past few years. Prior to the scheduling of gabapentin, we did have an alprazolam or Xanax in the top 5, but that switched over once gabapentin was scheduled. So this is just to give a snapshot of what we're seeing in Michigan. Next slide. So the next few slides are specific to county, patient county. So we took the patient address that gets reported to with each prescription. So we're looking at St. Clair County patient addresses. And I just have the 2 slides to show the scheduling, what we're seeing there, and then the number of patients receiving that opioid use disorder medications. So for each county, it's fairly consistent with the state as a whole as it relates to the scheduling. The decreasing between the Schedule 2, 3, and 4, and then the increase with the Schedule 5. Amber mentioned, and I think it's listed here right here in the chat, that this webinar or slides will be posted and available for your viewing later. If you have questions on any of the numbers related to any of the counties or the state, feel free to contact us towards the end or well after the presentation, and we can help you with that. Next slide. So St. Clair County, we're seeing an increase. You can see since 2017 to 2021, we have over 100 more patients since 2017 that are receiving MAT opioids. And you know, that's good. All of the counties are going to be the same. We're seeing that incline in the number of patients receiving care. Next slide. So we also have Macomb County here. Again, decrease in the Schedule 2, 3, and 4, and then the increase in Schedule 5 in 2019. And then next slide, you see the increase in number of patients receiving MAT opioids. Over 700 more patients receiving MAT opioids since 2017 in Macomb County. Next slide. Lapeer County, we have, again, the same. We actually had quite a few Schedule 2s in 2017, and those have declined and remained steady the past 2 years. Well, 2021 and 2020, and then Schedule 3 is also declining. Same with Schedule 4, Schedule 5, the increase, and you can see slight decline in 2020 and 2021 for Schedule 5. Next slide. A little bit of an increase, but still an increase. Number of patients in Lapeer County receiving MAT opioids. Since 2017, we've gone from 320 to 404. So it is increasing the number of patients receiving that treatment. Next slide. And then we have Sanilac County. I think this is our last county that we included in this presentation. Again, happy to provide additional counties if you need those. All of this information is gathered from the annual drug utilization report that's posted on our website. We've just done the analysis on these metrics for the presentation. Schedule 2, 3, and 4 decrease. Schedule 5 increase in 2019. Next slide. Sanilac County increase since 2017, just under 100 patients from 2017 to this past year, 2021, we're at 224 patients. And I'm not familiar with the population, but I would assume there's always more work to be done. Next slide. I am through the data slides, so I'm going to actually turn it back over to Amber. She's going to talk about another project that we're working on that sits right here with MAPS, and then go into the complaint enforcement process and some legislation.
Thank you, Haley. So one of the projects that Haley and I have been working on for the last couple of years is what is known as the Michigan Care Access Referral Exchange. And so in 2019, the department, Lara, was appropriated about $1.2 million to build an opioid treatment locator. And so essentially, again, the project came to Lara, and ultimately it's sitting with the Michigan Automated Prescription System. And the reason that it's sitting with MAPS is because OpenBeds, which is the platform for where my care is being hosted, is a Bamboo Health company. And because Bamboo Health, as we noted, has been administering our PDMP since 2017, we had this great relationship already established with them. We knew that they brought a ton of experience to the table. So we knew that moving forward with them and helping us build this opioid treatment locator was definitely the way to go with the project. And so once we started getting familiar with OpenBeds and what they already had established within Bamboo Health, we came to learn that it is a robust system. It is capable for much more than just an opioid treatment locator. And so essentially that is what we're working on, is this behavioral health platform, behavioral health care platform. It spans the spectrum of all behavioral health care, and it includes all service types of behavioral health care, not just that MAT. And essentially it helps to locate where there are services and then place individuals into that treatment. So it's a referral platform, not just a locator, but a referral platform as well. And then the system definitely has other capabilities as well. So when we began working on this project in 2019, we started partnering with the Michigan Department of Health and Human Services, because as some of you might be familiar, they have a legislative requirement to stand up a psychiatric bed registry. And so MyCare is going to be fulfilling that legislative requirement. And because of that, psychiatric hospitals across the state are also included in the system, and they are mandated to be included in the system. And so at the very least, and we've been working again since 2019, and we've definitely had some hangups with COVID, and the project definitely had to be put on hold within 2020. But then last year, last spring, we began work on the project again, and we've been moving throughout the state by regions and pulling facilities on board. There's not a mandate for all facilities to take part in the system, with the exception of the psychiatric bed, or I'm sorry, the psychiatric hospitals, because of that legislative requirement that DHHS has. But we've been successful in onboarding a lot of different types of the behavioral health care from different regions. We still have a ton of work to do, but our goal is to work our way through the rest of the state by the close of this year, and then do another sweep and pick up some of the facilities that we weren't able to get on, and then just continue to work on the project. So I definitely wanted to mention that that's another thing that we have in the works. So what time do we have? I quickly want to go through our complaint and enforcement process within the department. And so essentially, anytime that a complaint comes into the department, it is filtered to the appropriate areas, but most of the complaints that we see come into the department are done online now. And that can be done. I linked the website at the top here, and then just kind of outline the steps. You would hit file a complaint, and then you would choose the appropriate health license. In this instance, what our team is kind of related to is the health licenses, but there are the other licenses where you could file a complaint as well. But in this instance, you would choose the appropriate health license type and click on it. So, if it was against a medical doctor, you would click physician, so on and so forth, and then you would click file the complaint now. So the allegation is filed with the Bureau, and then it is essentially that complaint is reviewed to make sure that there's any initial, at first glance, anything to substantiate that complaint. And then generally it is sent to the appropriate authority board to review and decide if that complaint is going to be authorized for investigation. Because essentially, in order to impose any sanctions against a professional license, there has to be a thorough investigation done. So if an investigation is authorized, the Bureau conducts an investigation, and then a couple of different things can happen. The first is that the investigation shows that there's no evidence of a code violation, and in that instance, the case is closed. But a couple of other things can happen as well. First, the department can issue an order to cease and desist whatever behavior is happening. Also, an administrative complaint against that professional license can be issued. And if an administrative complaint I should say that this third one, an order of summary suspension can be issued. And if an order of summary suspension is issued, from the date that suspension is issued, the licensee can no longer practice until an investigation takes place, and ultimately a decision is rendered based on that investigation. But anytime number 3 happens, number 2 also happens. So anytime there's a summary suspension, an administrative complaint is taken out against the license. But number 2 can happen without a summary suspension essentially happening. So once the complaint is issued, there's a process that happens after that. So the licensee might choose to meet with a bureau representative for what's called a compliance conference. And essentially that's where that individual sits down with the department and says, this is why I did this, this is what I did, this is why I did this, and here's how I was in compliance with the public health code. If the parties can come to an agreement, essentially a consent is drawn up, and then that is sent to the appropriate authority board to review. And ultimately it's the disciplinary subcommittee of that authority board who has to review and approve or dismiss everything. And so if the agreement that the department and the licensee has agreed upon is also agreed upon by the board, then that consent order then becomes legally binding, and whatever that action was that was agreed upon is what action is taken against the license. But often after that compliance conferences, the two parties are not able to come to an agreement. And that's when there is a formal litigation happens. So it's a formal hearing in front of an administrative law judge where both sides argue their case. And essentially that administrative law judge at the end issues what they call the proposal for decision. And so what their verdict is on the case. But even in that instance, that has to be sent to that authority board. And again, that authority board can either accept that decision or they can reject it. And either way, they choose from there what discipline, if any, happens against that professional license. But again, whatever decision that board issues becomes binding in law. Whatever that decision is that becomes binding in law, the licensee can appeal through the Michigan Court of Appeals. And then just a couple of questions related to the complaint and enforcement process is, if I know that somebody has violated, if I have a colleague and I know that they violated the public health code, am I required to report them? The answer is yes. If I do file a complaint, will my identity remain confidential? And that's kind of twofold. You can choose to remain confidential when you file the complaint, but if it goes to formal litigation, you're asked to testify in open court. It's just that you're required to testify in open court where you state your name and then of course why you're there, so on and so forth. And then the same would be if you know that you have a colleague that's practicing while impaired, are you required to report that? And the answer is yes, you are required to report that. Have just a few minutes left. I have these Michigan controlled substance pieces of legislation. Most of them became enacted in 2018. I'm not going to go over these in any great detail, but I have them here for your reference. We haven't had any new ones that have passed for the most part since 2018, 2019, but definitely take a peek at these. And if you have any questions, feel free to follow up with us at any time and we'll do our best to answer those. And then I always like to link these safer prescribing practices and the opioid prescribing toolkit that the University of Michigan has created. And this is just kind of a snapshot of what some of those tools are. I think some of them are really great tools, whether you're a prescriber or some other type of practitioner. There's some really great links and tools here that might be of really good use to you. And then Haley and I's contact information. Again, you can contact us related to this presentation, related to MAPS in general. But if you do have a MAPS account, you can also, if there's technical assistance that you need with the account, the number that Bamboo Health has, the 844 number, is the best number to contact, or the rest of our team can be contacted at this email address on the right or the 517 number that's listed here. And then I want to leave a few minutes for questions here.
It looks like Haley answered the questions that were in the chat box. If anyone else had any questions and wanted to put them in the chat box. Oh, here we go. Denise has one more question. Are substance rehabilitation facilities going to be included in the referral exchange, Or is that just for mental health services?
The answer is yes, they will be included. So again, that's going to be spanning all of behavioral health care. That would be mental health and substance abuse treatment facilities as well. And the goal ultimately is for both inpatient and outpatient to be included in those.
Thank you.
Yeah.
And just adding to that, Denise, it looks like you were the one who had the question. We did begin work, if you're all in St. Clair County, which I assume you are, we did begin work in the Region 10 or the PIHP Region 10. So we might have talked to some of you before, but we'll be circling back to anyone that we've missed, or if you should be a contact for your organization, feel free to reach out to Amber and I, and we can make sure that we get you what you need to get onboarded into the system.
Does anyone else have any other questions they would like to ask before we wrap up? Okay, I'd like to thank you, Amber and Haley, for your time and information today, and to everyone for attending this session. To recap, today's presentation is one of many webinars scheduled throughout the month of September. You can still register for any upcoming presentations at sccmh.org. This PowerPoint presentation will be loaded onto the website under today's presentation. Thank you again for joining us, and we look forward to seeing you at our next webinar.